Welcome to This Explainer. Okay, let's just dive right in. Today, we're taking on a true masterclass in dynamic psychiatry. You know, in all my years of clinical practice, I found that our daily work requires us to bridge this massive gap. We're constantly bouncing between the hard, cold neurobiology of the brain and the deeply human, highly subjective, and frankly messy experience of the actual patient sitting across from us. This explainer is going to show you exactly how we integrate those two worlds, so you can become a vastly more effective, insightful therapist. I want to speak directly to those of you currently in your clinical training right now. Look at this quote from John Nemia. It really captures the sheer gravity, the profoundly personal nature of the work we do. We aren't just mechanics trying to fix a broken machine, right? To truly see into the mind of another human being, you have to immerse yourself in their feelings. You literally have to learn to use your own mind, your own self, as your primary diagnostic instrument. So here's our roadmap for today. We're going to cover the biopsychosocial person, dive into the subjective unconscious, look at how the past is prologue, unpack transference and countertransference, and finally wrap up with the neurobiology of therapy. All right, section 1, the biopsychosocial person. Let's look at exactly how we frame the modern patient. So what exactly is psychodynamic psychiatry today? Well, it's an approach that honors unconscious conflict, deficits, and internal object relations. But crucially, and this is key, it integrates them with contemporary neuroscience. We just don't live in an either-or world anymore where something is either purely psychological or purely biological. We practice in a very real both-and reality. To survive in this reality, you have to grasp explanatory dualism. Think about it. The brain is objective. It can be scanned, measured, and observed from a strict third-person perspective. The mind, on the other hand, is completely private. It's a first-person subjective experience known only from the inside. As modern clinicians, we literally have to become bilingual. We need to be perfectly fluent in both languages. When you combine the mind and the brain, you get the person. And let me tell you, a person completely defies easy categorization. We're looking at a huge mix here: subjective narratives, complex brain networks, cultural backgrounds, and internalized interactions with others. It's the whole shebang. Always, always remember, you are treating a totally unique individual with a rich history, not just a genomic sequence or a simple checklist of symptoms. Moving right along to section 2, exploring the subjective unconscious, let's take a descent into the hidden, murky layers of our patients' minds. Let's lean into a metaphor here for a second. Imagine a deep cave on a mountainside, and the entrance is completely blocked by a massive boulder. Descriptive psychiatry? Well, it walks right up to that boulder, measures its dimensions, notes the rough texture, and puts it in a neat little category. That's symptom checking. But dynamic psychiatry, we want to know why on earth that boulder was put there in the first place. We're the ones grabbing a flashlight, moving that rock, and actually exploring the dark interior of the cave behind it. Once we're inside that cave, we stumble upon different types of memory. Explicit memory, that's conscious, like recalling a specific childhood event. But implicit memory? That is unconscious, procedural. It's built into our connections. And let me assure you, your patients are going to reenact these implicit memories right in front of you, in the clinic, often without saying a single word. They will just automatically act out these early ingrained patterns of relatedness. Now, this is where it gets really cool. This brilliantly illustrates Freud's theory of repressed memory, but it's totally backed by modern fMRI data. During active forgetting, there's this reciprocal interaction between the prefrontal cortex and the hippocampus. When a person actively tries to suppress a painful, unwanted memory, their prefrontal cortex essentially dials down the activation in the hippocampus. The brain is actively, biologically working to forget trauma. It's absolutely fascinating. Okay, section 3, past as prologue. Let's see exactly how childhood experiences physically wire up the brain's circuitry. The absolutely crucial point I need you to take away here is epigenetics. DNA is not destiny. Take a look at the famous studies on rhesus monkeys and the serotonin transporter gene. Monkeys with a short, risky genetic vulnerability who were raised by just their peers, they showed high impulsive aggression and high alcohol consumption. But, and here's the kicker, monkeys with that exact same genetic vulnerability, when raised by a nurturing mother, actually had the lowest alcohol consumption and aggression. That secure maternal attachment literally buffered their genetic vulnerability. It's a real game changer. All right, section 4, transference and countertransference. This is the intensely practical, living, breathing relationship between you and your patient. So transference happens everywhere in life, right? But in dynamic psychiatry, we actually use it as a clinical tool. It's the ubiquitous phenomenon where a patient unconsciously reenacts a past relationship with you, the clinician. Junior therapists, please hear me on this. When a patient acts out towards you, they are bringing their internal world directly into your room. They are showing you, rather than just telling you, about their past. And we actually know where this happens biologically. The orbitofrontal cortex is basically the seat of right brain implicit communication. It forms the biological basis for those intense gut feelings or intuitions you'll inevitably experience right in the middle of a difficult session. Your right brain is quite literally tuning into your patient's right brain. It's incredible. But listen, we are not blank slates. While the patient has transference, we have countertransference. This is your total, jointly created emotional reaction to the patient. And I really want to validate this for you. Sometimes you are going to feel frustration or even anger towards a patient's provocative behavior. It's what Winnicott famously called objective hate. Actually, you know what? Don't view it as a personal failing. It is a vital diagnostic tool that tells you exactly how this patient makes other people in their life feel. All that push and pull inevitably leads to resistance. Think of it step by step. A patient feels threatened by painful emotions, right? So their unconscious defense mechanisms activate. And how does that manifest in your room? Lateness, awkward silences, or suddenly forgetting to pay. As a dynamic clinician, you must interpret that resistance as part of the actual treatment. Become profoundly curious about the defense rather than getting frustrated by the noncompliance. Which brings us to our final part, Section 5, the neurobiology of psychotherapy. Proving once and for all that talk therapy is in fact a powerful biological intervention. Nobel laureate Eric Kandel demonstrated using the marine snail Aplysia that learning from the environment physically permanently alters synaptic connections through the regulation of gene expression. Well, guess what? Psychotherapy is a highly specialized form of learning. Never forget that when you sit there and provide a breakthrough insight to your patient, your words are literally altering their gene expression and physically reshaping their brain structure. This is exactly why combining therapy and medication is so incredibly effective. PET scan research shows us that psychotherapy works top-down. It increases metabolic activity in areas like the anterior cingulate and hippocampus, which are linked to meaning and memory. Medication, on the flip side, works bottom-up, altering the prefrontal cortex and brainstem. They are complementary, but fundamentally different ways of healing the brain. As we bring this masterclass to a close, we really have to ground all of this complex neuroscience back into the humanity of the patient. Hippocrates hit the nail on the head thousands of years ago when he said, "It is more important to know the person with the illness than the illness the person has." All the fMRI scans, the epigenetics, the neurobiology, they are all just tools to help us deeply understand the totally unique human beings sitting across from us in our office. Which leaves us with one final, provocative question to reflect on. As a modern clinician, are you ready to become bilingual? Are you ready to truly master both the objective language of the brain and the deeply subjective language of the mind? Because if you can integrate both, you won't just be treating symptoms, you will truly know and heal your patients. Thanks so much for joining me on this explainer, and I will see you next time.